Hello, and a very warm welcome to today's ICE-NTD Connect. Thank you very much for joining us today. We are towards the start of the week that sees World NTD Day. A lot of energy and celebrations kind of building up, a momentum around this very special and unique day where the slogan encourages us to unite, act and eliminate. So we've done Unite, which is to all come together today for this webinar. The acting, I think, will be handed over to our amazing speakers today, and eliminate is really what we would love to achieve. And all that in context of sleeping sickness. It's really wonderful to take a moment to look at an NTD that is such a success story. It kind of gives us a moment to reflect on the fact this has been a terrifying disease with some of the worst epidemics that we can remember in global health. But at the same time, balancing that with this incredible progress, a reduction in 98% almost of incidence in the last 2 decades, thanks to the partners on screen with us today. But is that it? Are we done? Or what does the last mile bring? What are the next steps? So I think we're going to have a really exciting session. Thank you so much to our attendees for being here. But first and foremost, a huge thanks to our speakers. We will be welcoming and hearing first from yourself, Dr. José-Antonio Ruiz-Postigo. I'm sure many of those on the call already have worked with you, know you very well. You are from the Global Neglected Tropical Diseases Program at the WHO. Thank you very much for being here.
Pleasure is mine. Thank you very much.
Thank you, José. Next, we will hear from Dr. Philippe Neau. Philippe, thank you very much for being with us today. You are representing the Fondation S, the Sanofi collective, and you'll be sharing with us some of the incredible, really great game-changing innovations in treatments for this very complex disease. So it's a real privilege to have you with us today to share this.
Thank you very much, Marianne. So a good pleasure to be here with you to share the good news we have with sleeping sickness.
Wonderful, thank you. And joining us from the DNDI, the Drugs for Neglected Diseases Initiative, it's a huge pleasure to welcome the head of Human African Trypanosomiasis, Dr. Junior Matangila. Hello and welcome.
Hello, everyone. Thank you for inviting me.
It was a completely natural invitation, of course, with the tremendous role that DNDI is playing, not just in securing the treatments, but also ensuring their access and the outreach to communities, community engagement and awareness. So really a very packed 90 minutes ahead of us. If you are in the audience, please, I think you know the system very well. Sima Rafati, thank you. You've joined the chat already, but please do take a moment to say hello, where you're connecting from. Perhaps if you yourself work in sleeping sickness, or where your programs are running, and we'll have a chance at the end of the session for a bit of a discussion, also answering any of your questions. So without any further delay, José, I think I'm going to hand over the stage to you and the microphone, with the first hurdle being to display the slides. So I hand that over to you. And in the meantime, while you do that, I will just give a quick hello to some of those that have joined us. A very warm welcome to Kamalesh Chandralal, Johnson Uma, Alessandra Carozzi, welcome. Leo Brack, pleasure to see you all here on the call. Bridget Bannerman as well. Lots of friends and familiar names here. So we will have a chance to exchange in a bit. But for now, over to you, José. Thank you so much and welcome.
Thank you very much, Marianne. Can you see the slides properly?
Perfectly.
Thank you.
Thank you.
I'm presenting this on behalf of my colleague, Dr. Gerardo Prioto, who is now in charge of the sleeping sickness program at the WHO. I'm supporting him on some tasks. I work on sleeping sickness for over 17 years. I am now back to sleeping sickness from WHO in Geneva. So as you mentioned, Marianne, this is a wonderful graph, a nice slide where you can see for the last 24 years a huge decrease in the number of cases, mainly due to Trypanosoma brucei gambiense. So around 97% decrease from over 25,000 to a few hundreds of cases. If we look at rhodesiense, the trend is also decreasing from about 700 cases to less than 50 cases in the last 3 or 4 years. So 97% of the cases nowadays reported, in the last years was due to Gambiense trypanosomiasis. And nowadays with the decrease in the number of cases of Trypanosoma gambiense, the Gambiense represents 92% of the cases, and Trypanosoma rhodesiense is about 8%. So in this slide, you can see the data we have as of November last year, where the human African trypanosomiasis has been eliminated as a public health problem in different countries. Details about the countries where the disease has been eliminated are regularly published in the weekly epidemiological record of WHO, and here are examples of Togo, Cote d'Ivoire, Rwanda, Benin, Uganda, Ghana, Equatorial Guinea, and lastly, Chad. So the hot spots, the countries where still there is work to do, where the situation is more critical, is in Central Africa. So from Central African Republic, South Sudan, the two Congos, and Angola mainly. Here is one of the celebrations when Chad eliminated and the disease as a public health problem, even during the tough times around COVID. In this slide, you can see the status of countries regarding the sleeping sickness elimination as a public health problem as of November last year. So in the top right, you can see the countries, the list of countries that have been validated. It starts back from 2020, some 15 years ago, with Togo, Cote d'Ivoire, and last year in Chad. Two countries are on the verge of being validated. One is Guinea-Conakry, and Kenya. I think Guinea, we may hear some very good news in the coming days, but bear with us. And then in the other extreme, in the other side, we have countries, as I mentioned, that still do not meet the criteria, like Angola, CAR, Congo, DRC, Malawi, and South Sudan, and other countries like Botswana, Eswatini, Guinea-Bissau, Mozambique, and Namibia, where unfortunately surveillance is absent. So we don't know what is happening there. In between, there is this long list of countries that meet the incidence criteria, but unfortunately, surveillance is insufficient for WHO to validate that elimination. This is a publication to emphasize that now WHO is moving forward, even pushing the agenda beyond the elimination as a public health problem. And now the target is the elimination of transmission. And this is only for Gambiense sleeping sickness due to the epidemiology of the disease and the fact that the main reservoir is the human. Here is the status of countries regarding the elimination of Gambiense HIT transmission. And as you can see, as of today, we still don't have any country that has been validated. We also didn't receive any dossier for validation, but in the center of the slide, you can see already a significant number of countries that meet the criteria and that may soon submit a dossier. Again, in the left-hand side of the slide, we still have a significant number of countries where that criteria is not met. This slide is to emphasize and to highlight that the number of cases confirmed parasitologically has now increased. So decreased, and confirmed cases grew threefold from almost 4% to 12%. So this is good news because we are seeing more and more cases that are not confirmed, meaning the actual trypanosome is being observed in very few cases. And that trend is dropping faster than we had expected. So in this context, what are the new case definitions? So we have what we call a confirmed case, meaning that the parasite has been seen under the microscope. A probable case when we have the cat titer equal or above 116 plus other molecular tests. And we have now also this category of patients or cases that have a positive rapid diagnostic test or a cat in whole blood that we call sero suspects. Well, someone looking at that slide that I shared at the beginning could question, is the elimination stagnating? Because since 2018, there is more or less a stable number of cases. What is under that? Is the spatial distribution stable? We have some good news. What we can say is that most cases are found through active screening, meaning that there are a lot of resources invested in going and looking for the cases. So the elimination strategy is not mainly based on passive screening. Through that active screening plus the data analysis, there is an annual retargeting, and we go and look where those transmission areas are so that control or elimination activities are targeting where the disease is more prevalent. We are even doing or using this door-to-door strategy, which is more intense than what we used to do now with these mobile teams screening at village level. But now mini mobile units are really looking family by family, patient by patient. And again, to insist that the fact that the number of confirmed cases is decreasing faster than the total makes for us to say that elimination is advancing and is in the right track. Thank you for being here with us.
Thank you so much, José, for setting the scene so clearly. It was about a year ago, actually, that we had a very similar webinar, really charting this amazing success. And I will share the link to the attendees who can have a look. And it's really fascinating to hear in this past year, 1 year on, the mechanics. How is elimination progressing? But also, interestingly, you're alluding to some of maybe the areas where a bit more focus is needed. For example, developing surveillance. Also, this slight challenge posed by the two different types of sleeping sickness. So we can unpack that a little bit more perhaps in our conversation, but thank you. That was a wonderful presentation, and we wait with bated breath for the good news coming. You said any time soon, so we'll be keeping an eye out for that. Thank you. So Philippe, over to you. How are things looking like from a therapeutic perspective?
So thank you very much, Marianne, and thank you very much, José. José, you made a great introduction regarding where we are regarding sleeping sickness, and what I would like to share today is how together we can move on and continue to succeed in the elimination of sleeping sickness, and because today we are only 2 days in advance before the World NTD Day, the 30th of January. I think it's a great moment, Marianne, for sharing this. And what I would like to insist, and I will talk about this during my talk, is the partnership is critical to succeed, and no one alone will be able to succeed. And I will talk so 1 minute about the Fondation S, which is a Sanofi collective, meaning this is the philanthropic arm of Sanofi. And this organization is rather small, but we are leveraging all the resources inside Sanofi to help the most neglected populations in the world. And we also have a lot of partnerships. And here in this slide, I have described the commitment areas and the way we work. The mission of the Fondation S is to improve the lives of the most vulnerable populations, and really by having access to the medicines, but also having community-based solutions. And to build that, we have ways of working with first a think tank. We think about how we can help and support these populations, and consequently a do tank. When we have thought a lot of this, how we will engage, how we will make data evidence generation, having progress in the field, having projects with the populations. And this is a new way of doing philanthropy with having community-based solutions. We will work directly with the communities in the field to really find solutions which is the most adapted to the populations. And we have 3 commitment areas. One is the childhood cancer, because we know that in these countries, many child are not treated against their cancer. And a big also area is a climate action and health resilience, meaning that we are putting in place some projects locally in the populations to limit the impact of global warming, climate change, for the populations, and we have projects directly with the populations. And a third, which is a neglected tropical diseases project focusing on sleeping sickness elimination. And I will talk more about this because José just talked on the name of WHO, because Sanofi has started very early its collaboration with WHO since 2001. And every 5 years, we give 25 million to WHO to have a better screening, to put capacity building in place, education, awareness, and really to make sleeping sickness as a key priority in the countries. And we are donating also all the drugs to WHO. So I will come back on this, but moving forward, we are committed to continue to support the WHO, and the goal is really to succeed in the elimination of sleeping sickness by 2030. So here you can see the same slide, same graph that we have seen with José. And yes, the last 5 years was under 1,000 patients, which is great news, with a decrease of more than 97% of sleeping sickness cases since 2001. And this is thanks to the partnership we have put in place with WHO, but also, and we talk further about this, about the partnership we put in place with DNDi since 2009. And in this context, because WHO was able to build in the countries an ecosystem to control, to have educated people about sleeping sickness, DNDi was able to launch clinical trials in the countries, and they were able to do that in very difficult conditions, very remote areas, in countries where conducting a clinical trial is very, very complex and difficult. And this is how DNDi was conducting the clinical trial there with fexinazole. And at the end of the day, fexinazole was submitted by Sanofi to the authorities and obtained a positive CHMP opinion in the countries after having an EMA positive opinion in 2018. And today, fexinazole is the first full oral treatment for sleeping sickness. And maybe I can put the other slide. And knowing that today 70% of the population is treated with fexinazole today, and it is a great advancement for the population, and now the population are much better access to this drug. When I was speaking about very good news, is that in parallel of putting in progress the use of fexinazole, DNDi was able to conduct clinical trials against the Rhodesiense patients. And clinical trial was conducted in the endemic countries of Rhodesiense. And we were able to submit the dossier to EMA and obtain a positive opinion of Rhodesiense in December 2023. Very quickly, because we were working hand in hand with WHO, we were able to see WHO guidelines, updated guidelines early 2024. And now there is also very active work in order to facilitate access of fexinazole in the Rhodesiense countries. And hopefully within few days, we will be able to announce the first patient treated with fexinazole in Rhodesiense type of sleeping sickness, avoiding the use of this very toxic drug, which is arsobal. So more to come. And I was speaking also about new treatment, which is coming also soon, because DNDi was able to develop, again, with clinical trials in Africa, a new oral treatment, acoziborole, which would be the first treatment for 1 day treatment, 3 pills given at once. And we have already very good results, clinical study results with a pivotal study. And all the teams, DNDi, Sanofi, is working very actively to submit the dossier this year to the authorities. Meaning that very soon we hope to have also, in addition of fexinazole, the possibility to use acoziborole. So trying to do the next slide. We were able to do that because we were able to embark everybody, from R&D, meaning clinical development with the NDI locally, in a very good standard, development as per standard of other drugs for EMA or for FDA. partnering with all the key stakeholders, having a regulatory strategy appropriately used for this type of population. When I say appropriately, that means that again we wanted to embark the local countries, having capacity building in these countries, to propose to the countries to participate to the review of the EMEA. And I think this is also accelerating afterwards the access of the patients to the patients of the drug, and the distribution also. We are giving the drugs to the WHO, and Médecins Sans Frontières (MSF) is distributing in endemic countries the drugs in partnership with the national heart control programs. So maybe one important also thing I would like to mention is that we have very regularly with WHO meetings about what are the needs for drugs, where do we need the drugs, how much, for how long, etc., in order to avoid any shortage of drugs for these populations. And I think this is key also in the success, because we must not see any patient not treated. This would be my only last slide. When I say that only collaborative approach will succeed for elimination, because we need to be in a long-term partnership approach. It will take time to fully eliminate the disease. We need to continue to partner. We need to continue to work together. We need to continue to develop the drugs for all the type of populations of sleeping sickness, including pediatrics, including serosuspects, as mentioned by José previously. We need to be sure that despite the fact that the disease is disappearing in the countries, we need to continue to have the countries' empowerment, countries' involvement in the working against sleeping sickness and global health approach, because we have a disease transmitted by vector, the tsetse, we're having a parasite, and we need to control these. And ultimately, maybe one word regarding the diagnostic, because diagnostic will be a key element moving forward elimination. We must have a diagnostic very good in place to control the elimination, because if we stop to test, if we don't have a correct test, we may lose the thermometer to continue to be sure that we have eliminated the disease. And this is, I think, the work we still have to do together moving forward elimination of the disease. So I hope you learned some new aspects of some new good news regarding where we are regarding the development of the drugs and access of the new drugs to the patients, and looking forward to continue to work together for the success of elimination of sleeping sickness by 2030 as per WHO and the roadmap. Thank you very much.
My goodness, more good news about to drop. That's an amazing few days ahead of us we have. Thank you very much, Philippe. It's great that you really put this focus right at the start, and you concluded on highlighting this need for long-term partnerships. How you've done it, the way you've reached out to so many different stakeholders and really kept that going for more than 2 decades is extremely inspirational, not just for sleeping sickness, but for many of the neglected tropical diseases where this needs to be replicated. So I'm not surprised that the do tank concept comes from your team at Sanofi. I like that, and we can't wait to see the next steps. Thank you so much, and congratulations.
Thank you very much.
So Junior, clinical trials, the crucial stepping stone. Oh, sorry, we have a bit of interference.
Sorry.
All good now. So over to you, Junior. DNDi is so instrumental in many ways in this amazing success story of sleeping sickness. We'd love to hear an update from you. So over to you.
Thank you. I'll focus on some aspects describing how the journey was hard to develop the drugs. And also, I'll share with you some internal thoughts, some internal discussion we are having for the future. So, developing novel treatment to support elimination of sleeping sickness is our ultimate mission. And we are talking about a disease that is seriously debilitating and deadly, putting at risk more than 3 million of persons. And these persons are located in these regions in yellow. I will not come back to what have been nicely described by Jos, but I would like to just come back to this graph describing the number of cases for the Gambiense Act. We can see that over the past decade, we have observed a steady or a drastic decline of the number of cases. But since 2018, it looks like we have reached a stalemate or a stagnation. But looking at the servers, seems that it's a stagnation. But thanks to José, who have given us an insight in what is happening in the deep analysis of the data. But one could still think that the actual or the current measures that have been very successful in declining the number of cases are not enough to break through and take us to elimination. There is a need to develop new strategies, including new drug and new diagnostic tools to make sure that we are going really toward elimination of the sleeping sickness disease. So our objective, which is a common objective, is to interrupt the transmission of this disease by 2030. But the way we as DNDi contribute to this common objective is by developing drugs that are simple, safe, and effective, and that can be used in the environment of the patient. And this environment is characterized by limited access, limited infrastructure, and limited number of trained staff. So this slide summarizes what we have done so far, or what we have contributed so far for the fight against the sleeping sickness. So over the past decades, the only treatment available for the disease was the melarsoprol, which is known to be very toxic and deserve the nickname given by patients, which given name is fire in the vein, because the drug is known to be very painful when administered. So our first move was to develop the NECT, which is effective and safe, but it's still an hospital-based treatment because the patient needs to be hospitalized. A lumbar puncture needs to be performed in order to stage the disease, and it needs a very cumbersome logistic or complex logistic. On this picture, all you can see on the table is the treatment for one patient. Then, almost 10 years after the NECT, we developed the fexinidazole, which is the first all-oral treatment given in 10 days. So this was really a turning point for the treatment of sleeping sickness. But the problem with fexinidazole is that it's still somehow an hospital-based treatment, because for some patients, the lumbar puncture is still needed. Then in 2023, this fexinidazole oral treatment was also approved for the rhodesiense form of sleeping sickness, and the drug is also aligned or accepted in DRC for the treatment of rhodesiense. But as the molecule is still a hospital-based treatment, we wanted to develop a similar treatment. And the goal for us is to develop acoziborole, which is an innovative single-dose oral treatment to sustain elimination. But let us discuss how long and hard was the journey to develop all these treatments. For the NECT, the journey started in 2003, and DNDI with his partner MSF Epicentre, Swiss TPH, and DRC Control Program conducted several trials in the country to evaluate the efficacy and the innocuity of this treatment or the safety. In 2009, the drug was included in the WHO essential list, and the drug is donated by Bayern and Sanofi. Thanks to them. But as I mentioned earlier, the drug is still an hospital-based medicine because you see that the patient need to go through a traumatic lumbar puncture, and it needs a very complex logistic to reach the patient. Then we developed the fexinidazole, and the journey started in 2007 with the selection of the drug as a preclinical candidate. The journey progressed through several clinical trials that have been conducted, and it was a very hard work because around 2 million of people were screened and 750 patients were included in all these studies conducted. And in 2018, the drug was recommended by EMA and approved by the DRC. The first treatment out of the clinical trial was treated in 2019. The same drug was also, as I mentioned earlier, accepted for rhodesiense, the chronic, the acute and acute form of the disease, and it was added as in the guideline of the WHO treatment. Now, looking for the future, we are developing acoziborole. The drug has been identified as a potential treatment in California. The first trial was conducted in France in 2012, and many other trials were conducted from 2016 to 2020. Now we are in the process of submitting the dossier to IMA, and the targeted period is Q3 of this year, and we are closely working with Sanofi for that. Now, as I mentioned, showing the graph, we think that the current strategy, which are based on the large-scale screening, on the laboratory confirmation, and the treatment of only confirmed cases, is no longer effective to take us through elimination, and we need a paradigm shift. And for that, we need some tools, and these tools include adapted drug for new strategy. And the strategy we are thinking about for the future is the test and treat strategy, which will also require a large-scale screening, but the treatment will not be only given to confirmed cases, but to suspected cases for people who will be serologically positive. But we think that the laboratory confirmation will still be maintained. This will be for the surveillance purpose. And we also think that in the near future, we need a transition from fexinidazole, which is still an hospital-based treatment and a long treatment of 10 days, to acoziborole, which is a single-dose treatment that can be given outside of the hospital. But for this, we have some we still have some few steps to achieve. We need to document again the safety of acoziborole. We have enough data to prove it, but we need additional data as we are planning to give it to people who are not sick, who are just suspect. So we are conducting, we'll see in the coming slides, some study to have more data, to gather more data on the safety. We also need to prove the safety and the efficacy of this drug in children. And we also need to respond to a very crucial question, which is regarding pregnant women. So as I said, the next step are to have additional data on the safety. And for that purpose, we are conducting a STROGAT study, stops transmission of Gambiense trypanosomiasis. The study have started, and we have so far enrolled and treated more than 200 patients. We are also conducting a study in kids. It's named OXA-05, because we also need to have a treatment for children who have less than 6 years of age. Now we are internally discussing about the acoziborole in pregnant women. The preclinical experiments have shown that there is no problem, no hazard with acoziborole in preclinical studies, but no data have been collected in pregnant women in the frame of a clinical trial. But we have a record of a few number of accidental pregnancy which occurred in 2 studies we conducted, OXA-02 and OXA-04. We accidentally record these pregnancy data, and analyzing this data, we could see that there were nothing or no problem with pregnant women and with newborn who were exposed to acoziborole. But we still need to find a way to collect more data, because if we are planning to use acoziborole in a test and treat strategy, the benefits and the risk for pregnant women will be different than when we are administering the treatment to diseased patients. So we need to have a very, very safe drug and to find a very ethical and acceptable way to collect data in pregnant women. Another discussion or reflection is the acoziborole for Rhodesiense sleeping sickness. We have this new drug which is very promising, acoziborole, but we need to extend its use as we did for fexinidazole to Rhodesiense at treatment, because for the moment there is no treatment for the stage 2 of the disease. The treatment only relied on melarsoprol, and we really need to fill this gap. But given the rarity of the disease, it's difficult to implement a traditional clinical trial to collect data. We cannot rely on the preclinical model, which shows that acoziborole acts on the same target for both disease and have shown the same efficacy for the 2 species of the parasite. But the problem is that we still need some data, clinical data collected to prove that the drug is effective. We are thinking about the extended use of acoziborole and using the pharmacology system of the country to collect data and to finally prove that the drug can be effective and safe for Rhodesiense treatments. This was my last slide. Thank you for your attention.
Thank you so much, Junior. That was really, really informative, and it was wonderful to have the chance with you to pause a little bit and look at all those different iterations of treatments. It's quite hard in a 90-minute session that's very much forward-looking and in a positive light to really remember how terrible, not just the disease, but how actually terrifying the treatments themselves were. And this is really a great moment to congratulate the 3 parties on screen at the moment. Also others in the audience. You mentioned Swiss TPH, Professor Burry's in the audience. And so congratulations to all those involved. I think Delia Martinez-Mendez, you've really summarized it wonderfully in the chat. For those who can't read it, Delia says congratulations and capital letters thank you to all the technicians, health personnel, community members who participate in field diagnosis, care for patients, care for people, and provide us with the reality of this ruthless disease, neglected by almost all international health systems. My recognition and gratitude. There is much to do, but thank you for doing the best you know how to do. And that really is what it's about, translating into that for the affected communities, the patients. So really a huge round of applause on the occasion of this World NTD Day moment for this. So really wonderful to hear your perspectives. Some great news coming up on the horizon. And perhaps my first question would be, given all this, and we're talking about this very ambitious 2030 elimination target, so what really, in your opinion, would be the one thing that needs to accelerate and happen at a much faster tempo? Is there something that the wider NTD community can engage much more with to facilitate this progress in sleeping sickness? Perhaps we can go around the speaking order of presenters. This is the classic moment of any webinar. You're on mute.
Yes.
Yep, thank you.
Thank you, Marianne. No, the first is to acknowledge and to thank Sanofi because, well, as Philippe showed, for the last about 24 years, they believed in what WHO was doing at the beginning. We were the main actor, then others came on board. The NDI impressive achievement with these oral treatments. And I think here the challenge, and I thank Philippe for what he said, that despite the success, they are still planning to continue supporting all those efforts in a moment where someone could say, well, it's just a few hundreds of cases. So we could be punished by the success. And the fact that there is still this commitment of the researchers, this commitment from Sanofi to understand that in the last mile, every case, let's say, becomes more expensive. That is really good news for us. So I would like to emphasize this. And then the bad news are beyond all of us. Still, sleeping sickness is happening in countries, an area where there are armed conflicts, where it is difficult to access, and we need to be humble and recognize that unfortunately, despite we have those wonderful means for the diagnosis, for the treatment, still the social context does not allow us to reach everywhere. So this is my quick reflections. Over to my colleagues.
Yeah, maybe. Thank you very much, Jose. I can continue on this, and fully agree. We are on the verge of a very, very difficult moment because there are less and less cases, and some countries are announcing elimination. But yeah, there is two eliminations, we are between us, and we know that there is one elimination of public health problem and one elimination of transmission, and it's another story. It's important that people are not mixing this, because some countries are announcing and will announce very soon elimination of the disease, and some people of these countries just call me. So now we will stop to fund the program because it's eliminated. No, you have to continue. We have to continue to invest, and we have to continue to have knowledge of the disease, and we to avoid the risk of having again the disease in a country which have announced elimination. And this is critical because otherwise we will fail. And also, I would like to come back to my conclusion on the global health approach. Is we need to have also people controlling the disease in animals. Continue to control the vector, continue to control the tsetse fly, especially in the moment where the climate is changing. We can see the habitat of the vector changing very quickly. We need to continue to measure this. And the diagnostic piece, because we were able to manage with a very specific way the diagnostic. Before to treat people in the WHO guidelines, we need to find the parasite in the blood. And in the future, while we will move forward, we will need to have some different approach, and we need to test and to test millions, and the day even in 2030, where we will have announced elimination of transmission, we will have to continue to test for years. and this is critical to have all the partners, including diagnostic partners, having the knowledge on this. With now, we have new tools post-COVID, and molecular biology approach to have good tests and easier way with easiest approach to test. So that is my wish to not forget all the partners around our discussions, because of course we are focusing on medication. We are focusing, and it is great. We are making great progress, but we must have everybody around the table.
I've been taking many notes. Thank you for this great points.
Mm-hmm. Yes, I'm aligned with the comment of my colleagues. And what I would like to say is that the history have taught us that as we are learning the parasite is also learning how to fight against human. Because anytime we take a rest, the parasite works hard, and epidemic of the disease re-emerge. As we are going toward elimination with the declining number of cases, our government, I'm talking about developing countries, may be tempted to direct efforts toward other issues, other problems, because unfortunately we don't have only human African trypanosomiasis as problem. We have many other diseases to deal with, but very little resources. And this is a very dangerous situation. So we need to be close to the program and to the Ministry of Health of this country and explain to them that we are at a very important turning point. We need to invest once for all our effort to eliminate the disease. Because if we direct resources, staff, and other resources we have toward other issues, the disease will come back, and we will have to face the same problem, and this will need for us to increase, to invest effort, money that we don't have for now. So we really need to discuss and to make them understand that we cannot afford to decrease effort at this time. Yeah.
Some fantastic points. Thank you so much. And whilst we are talking about sleeping sickness today in this session, this is really where many of the neglected tropical diseases are kind of coming towards. And so solving this or building that case and that message will very much be useful, whether it's guinea worm disease or lots of other diseases nearing this big 2030 elimination mark. How do we keep the investment going, especially when the news is good? So that's going to be something very important to reflect on in the next few months. So thank you for highlighting that. It's really interesting you mentioned the animal health and vector control, Philippe, because that was actually going to be my next question. In parallel to this amazing game-changing approach to treatments, there's also been a lot of fantastic work in terms of understanding the tsetse fly a lot better, and also vector control interventions. And so do you feel that the two powerhouses of sleeping sickness control are working together enough? What is it like in the field, or do you think this can be improved? And if so, how can we reach this One Health partnership that we so often want to see happening a lot more concretely? I don't know if anyone particularly wants to go first. We don't always have to put José first, but we can if we really want to.
So maybe having the idea from the field because this is happening there. So maybe I would be curious to have the information coming directly from the field. Junior?
All eyes on you, Junior.
Yes, the big challenge is that all the countries are not facing the same situation for both disease. Like talking about countries in the West, like DRC, who is bearing the highest burden, reporting more than 60% of cases. We have the Gambian C4. So our government and our strategy are directed toward this disease. So it's difficult to have all the country facing the disease having an harmonized view on the two species. This is the first thing. And we need to invest in the transboundaries intervention. This is very critical. You know, animals are moving, crossing the borders, and the tsetse fly too. So some country may be acting good, putting all efforts and advancing, but they can be pulled back by countries sharing borders with them who are not performing like them. So these countries need to be organized and take time to put efforts going at the same level to deal with the disease at the borders of the country. So for me, these are the two main issues we need to deal with for rhodesiense.
It's a very important dimension. Would anyone like to? Yes, José.
No, again, I think here for rhodesiense, if you remember the slide where I shared the number of cases at least reported to WHO, which doesn't mean this is the actual number of cases, but we had 24 cases reported. So if you divide that by the number of countries that are endemic, how can you convince Ministry of Health or other ministries involved in animal health to say, look, you had 5 or 6 patients and now you need thousands or millions to address the fight against the tsetse fly? I think it's very difficult, and it was acknowledged. I mean, it has been known for many years, the role of the tsetse fly, the role of the animal in rhodesiense, and no one questions that. But the resources that you need to address that, I think, well, it's not easy, and at least from our side, no, the organizations and the institutions that work mainly on the human part, I think it's already important if we emphasize that in those endemic areas, someone with an acute fever, with symptoms of rhodesiense are properly diagnosed very quickly and treated, because I'm pretty sure that when we say there are hundreds of thousands of people dying from malaria in Africa, some of them were dying from sleeping sickness. But in Africa, in general, when you have acute fever and you died within a few days, well, you had malaria. So at least we should ensure as medical community to have the diagnosis and the treatment for the human cases.
Right.
The control will be ideal, but at least if we could avoid people dying from TB rhodesiense, that would be a very noble target.
Yeah.
Over to you.
Yeah, maybe I can follow up on my favorite discussion about diagnostic, because when you mentioned that the fact the fever, the first sign of heart sleeping sickness is fever. Of course, it's very common, and ideally we would need to have some kind of test which is testing malaria and heart, and then in this situation we would be in much better security, because of course in this situation we know that many cases of malaria, but if we have this test able to also measure heart, it will be much easier, because we will continue to test for malaria, and in some cases we will have the heart, and this is where also I am really trying to shake on this diagnostic piece, because this is critical. This is critical in addition of having dedicated molecular tests for heart, but to have some kind of mixed test, and I think again we need to have our friends of diagnostic with us to say how can we do that, and I'm trust with the gain of knowledge we have done very recently with COVID. We can leverage this and work in partnership with molecular test companies to do it. I trust them. we should be able to do that in the momentum of moving forward elimination. And to come back to the vector control, yes, how to agree that it will be much more difficult now to ask the countries to continue to invest of vector control when they have 10 cases, when in parallel there are hundreds of thousands of dead people for other diseases, and this is critical to continue to vector control too.
You use the word leverage, Philippe, and that's really interesting because this may or may not apply everywhere, but also leveraging farmers' interests sometimes can really help make the case for treating cattle and so forth. So there could be certain optics where that could work. Jason Oma in the chat was also, thank you for your comment, also adding we should not forget the One Health nature of HAT, particularly rhodesiense. Local partnerships and collaborations are key and should be encouraged. For sure, that's a really good point. Thank you. And some other febrile illnesses that are causing a lot of headache for health authorities around the world. I think we can also leverage chikungunya and dengue, and perhaps bringing all those together in some kind of surveillance diagnostic testing might just leverage partners' resources. So a really good point. Thank you. Derek Robinson was asking, you can always use the zoonotic aspect to emphasize the massive problem in animals. Thank you. So I wasn't sure if, widening the lens a little bit, I wasn't sure if, I thought, should I bring this to the conversation or not? But I guess it's now appeared in the chat. Manuel Luberas is asking, and it is World NTD Day. We are in a really odd week, given a lot of announcements in the media, but I think it is a good point, and it is maybe a good time to ask without getting too political. Obviously, things can change. Big forces in world politics or just how things are done do affect global health, public health. We know that because we all lived through COVID, the pandemic, and the decisions being made. So Manuel asks, what effect, if any, will the changes in public health policy seen in the new US administration have on maybe not acutely sleeping sickness, but just more generally neglected tropical diseases. You don't have to speak particularly to the US or particularly politically, but just in a general sense, like if we think of NTDs as a whole, and it is many of them, 54 countries have eliminated at least one NTD. The movement is going in the right direction. How can we protect that when global forces can be unpredictable, whether politically or economically?
Very, very, very complex question, no? And because, as you said, well, which percentage of the answer is going to be medical and which one is going to be political?
Yeah.
So, from my side, from WHO, I would just summarize that we are an organization that acts globally. And as we saw with COVID, no, something that happened in a town that no one knew about it, in a country that we felt it was very far from, at least from WHO in Geneva, look, it capsized the whole world. So at the end, we are in a planet that there is not anymore something that if you decide something in one direction or another in a country or in a region in the world, the effects can be felt worldwide.
Yeah.
So I will just summarize that. Wait and see. Yeah, there are changes. Definitely for WHO, there are things going on that we need to wait and see. And we will try to align ourselves with the principles of the ethics, the science, the public health, because the whole planet is at stake. Over to you.
Maybe if I so I think one way to continue to invest in NTDs and maybe in sleeping sickness case is to show to donors, to Western countries, whatever, today, that this can benefit to them. Example of sleeping sickness, we can say that all the work we are doing today has contributed to help some rich Americans, Europeans coming back from Africa after chasing elephants, not elephants, but other animals, and coming back with what is in the case of sleeping sickness. And after, they are so happy to ask WHO to send them, or Sanofi, to send them sulfexinazole. And I say, so thanks to the work we have done for neglected populations, a rich population can benefit of it. This is one example. If we think about dengue now is knocking at the door of all Europe countries and even in Americas. And all the work we have done for this entity is benefiting now for Europe and US. The same for Chagas. Chagas also. We see movements in the US and with the climate change, we can see more and more diseases coming in countries where it was not existing before. So I think we may leverage on this communication aspect and say, okay, you are not giving to the poor, you are not giving to neglected populations, you are also giving to you. And this may be also a way to say, hey, stop, do not stop to help, because at the end of the day, you will have a flashback.
Yeah.
Yeah. For me, this is also a message for the government of this country affected by these diseases, that it's also a call for more appropriation of the fight against these diseases. Because we need to be cautious and responsible, that if other people in the West cannot pay. We are the first to be affected by these diseases, and we need to take action.
Yeah. Fantastic. There's a real sense of, coming from your three responses, just a sense of really kind of getting some independence from those big forces and carrying on with as much as possible. You know, you were saying wait and see, Jose. Basically, don't panic and take ownership and carry on. And if there's certainly one thing that are all convinced of is the ability, particularly in sleeping sickness, WHO, DNDi, Sanofi are just a dream team. And I'm sure the partnership, the collaboration will continue for a long time. Manuel Luberas, who kind of brought the topic to the discussion, was also adding as a public health entomologist who's worked in Africa repeatedly. I remain available to help in any way I can. We are coming towards the end of this session, and so it seems to me that every year I have the immense pleasure of hosting a session on the fantastic progress on sleeping sickness, and you know, it's very inspiring. It's really a beacon of where NTDs can go and the strength of these long-term collaborations. And so if you were to come back next year, could you give us, we've had a few glimpses into some very exciting announcements that are coming up, but what are we to expect in the year to come? You know, we'll be getting pretty near that 2030 milestone. What should anyone in the audience be looking out for in terms of sleeping sickness? What do you feel the next steps might be?
Well, from my side, sorry, I'm starting again. Well, I think the first good news would be that, as you said, in 1 year, we are again here, meaning that the collaboration, the partnership, the impressive, really joint efforts that we have deployed in the last plus 30 years, they don't go away. That is the first thing. Mm-hmm. The second is being a fatal disease. I think it's crucial that we develop, as Philippe was saying, that capacity to diagnose promptly any case. And thanks to the amazing new oral treatments, even though there will be cases, or they may be cases, at least no one dies from the disease. Mm-hmm. I think one thing is to say this number of cases, but when we go and look at that graph, and if you say, okay, there were 500, there were 400, we wanted it to be only 100. Okay, there were 500, but were all alive? And if that is the case, because they were promptly diagnosed and treated with a very effective and drug without side effects, to me, that would be already a major achievement, regardless of whether we still have 100 cases or 200. So looking forward to hopefully being here in 1 year and to share more good news. Over to you.
Yeah, and really, yeah, fully agree with you, Jose. And I think the goal here is to have no one dying from sleeping sickness.
Yeah.
Knowing that we need to be sure to continue to have enough drugs everywhere where it is necessary. And believe me, this is a lot of work we have internally in Sanofi to be able to continue to produce, to donate, to extend the shelf life of the drugs, to work hand in hand with WHO in order to be sure that we will have enough drug, we will be able to send it in the place where it is needed, and including with the new drugs arriving, which is a lot of work, as you can imagine. This is fully new drugs. And yes, this is the first good news we can bring and say, yes, today we have better drugs better treatment, less side effects, and in addition, we are able to treat everyone. But again, to be able to treat everyone, we want to know that there are patients. We need to continue to test millions. Another good news I wish, and I'm working on this, is to be able to announce that Sanofi is making another 5 years donation for the WHO in order to go to 2030 for the elimination as we committed. So, and of course, another very important point would be how we move forward regarding the dossier we had submitted to EMA, the questions and the confirmation of the efficacy, the safety, and and moving forward, having acoziborole in the field for the next years.
Wonderful, thank you. And Junior, I think your role at DNDi as head of HAT is quite recent. Yes, October of last year, right? So I'm sure you have many plans.
Yes, many plans, many things to learn, because DNDi is a big organization, and I joined this group and this position while a lot of have been done by other people. So I'm trying to catch up and discovering very exciting work that have been done. And I'm happy to help to achieve this wonderful and impressive goal of eliminating HAT. But just a comment for Jose, don't be afraid to start, because you are the WHO and you are leading us to So it's normal even here in the webinar that you start. Yes, and I'm aligned with my colleagues. Our short-term goal is to have a very safe treatment for these patients before elimination. If we can manage next year to put away melarsoprol and have this patient to be treated with a very safe drug, this will be a great achievement. Over.
Those are very inspirational words. Thank you. And so congratulations on the new role. And clearly it's in very good hands. So we will be more than excited to follow all the exciting developments and news and milestones that lay ahead. We do have a few minutes left. Just very briefly, if Emily Negetish has just popped a question in about so we've heard about the gaps in diagnostic. So what is the current diagnostic method for trypanosomiasis, either in humans or animals? Or very briefly, what might be your chief, the main limitations with what is available at the moment?
Yeah, the very limitation that we have, for example, for rhodesiense is the lack of a rapid diagnostic test. So yeah, we don't have any screening test for rhodesiense HAT. This is a challenge. And for gambiense, the problem is that the parasitological confirmation is a complex analysis to perform, and it needs well-trained staff for it. And as you know, the problem with this disease is that it affects people living in rural area where infrastructure is very poor. So having a very simple to use test to diagnose the gambiense that can be used by even a relais communautaire, I forget the name we use in English, can use, this will be very helpful. Yeah.
Community health worker.
Community health worker. Thank you. Yeah.
Wonderful. Well, thank you for this answer. I'm not sure, Jose, Philippe, do you want to add anything to this?
Yeah.
No?
Yes, really straight to the point.
Wonderful. Well, then, all that's left for me to do is just to picking up on some of the comments from our audience. It was a real pleasure to have you online. Olaleye Olusola from the Nigeria Institute for Trypanosomiasis Research. Thank you for joining us. And you were saying thanks for the great presentations to all our speakers. Clara Lima, thank you, ISNTD, for this opportunity, and a big thank you to Dr. José, Dr. Philippe Neau, and Dr. Junior Matangila for their sharing their expertise and lifelong work on HAT. Same from Basile Goncha. This presentation was very informative, so insightful. Thank you. And finally, Monique Wasuna, joining us from DNDi. Thank you for the insightful presentations and your contributions to the fight against NTDs. There is still so much to be done for us to successfully eliminate NTDs, but together we shall succeed. And Professor Christian Bari was just sharing with us his dream expressed some 25 years ago that may now become possible to diagnose and treat HAT like any other ordinary, in brackets, infectious disease. So on those absolutely lovely words that I think really capture the sentiment, we want to thank you one last time for your time. It's an incredibly busy week in an even more busier month. So we really are grateful. A few people have asked if this will be recorded, and yes, these are recorded. They're always posted on our website and the YouTube channel. So please keep an eye on that, and we can email you the link as soon as it's available. So on that note, just very big thank you to everyone who joined us, to our speakers, and see you next year, if not before. And we will keep an eye out on all those amazing news and milestones coming up. So thank you and all the best.
Thank you.
Thank you.
Bye-bye.
See you next year.
See you next year. Yeah.
Let's do that, yes.
Take care.